Hey, I'm Scott. I'm the director of point of care ultrasound education for the internal medicine residents, and we're going to go over some basics today. Here's your objectives. We're going to learn some stuff about the physics and the probes, and two of the settings. Advantages to ultrasound, it is dynamic. So instead of a still like you get with a chest x-ray, we get a more informative set of images in a cine loop or a video. You can look at how tissues are behaving in real time. There's no radiation exposure, so it's helpful in patients that get scanned all the time, or in kids, for example. It's portable. Take it to the bedside. Patient doesn't have to move oftentimes for you to get the views that you need. And if they do have to move, they can stay right in their bed. You can just unbutton their gown a little bit or lay the bed a little flatter. And you can take it up there and monitor disease progression or response to therapy. You can do it every day. It's not expensive, right? So for a POCUS exam, oftentimes I'm just asking a single question that I want to know the answer to, and oftentimes it's binary. So, I wouldn't need to order an entire radiologic study. Oftentimes when you're ordering something like a CT or a formal ultrasound to answer one question, you end up with a lot of incidental information you're not sure what to do with. And that begets more testing and this sort of cascade of expensive procedures and testing that patients are exposed to. This graphic demonstrates the average speed of sound through different tissues in the body, and most ultrasound machines are going to use this constant of 1,540 meters per second to do echo ranging. So the impulse is sent into the body. The machine is counting 1 Mississippi, 2 Mississippi, 3 Mississippi until that signal comes back. And it's saying that signal was traveling at a speed of 1540 meters per second. It took this long to come back, and so it must have come from this depth. The number of signals that come back from that depth or their return at that time, that's what informs how bright it is. So that is echo ranging. Now you're a physics master. We see things on the screen from anechoic to hyperechoic. So anechoic, no echoes. Think like anuric is no urine. It's transmitting all of the ultrasound, so stuff is traveling right through. It's not bouncing off anything, not reflecting off anything. This is blood. This is ascites fluid generally, or a pleural effusion. Any other liquid that's going to be in the heart is generally anechoic. Hyperechoic structures reflect a lot. So areas where there's a lot of reflection, generally that's where two tissues that have really different acoustic impedances come together. So think like the intercostal muscles and the air-filled lung. So you have that pleura sort of separating the two. Very different speed of sound in that muscle and even in that pleural tissue versus that aerated lung. Same with like the liver to the diaphragm. You have a very significant difference in the acoustic impedance between those tissues, so a lot of the ultrasound is reflected at that point. In between, we have like various degrees of echogenicity. So that's what shows up as grayscale on the image. So here's just an example of that. We've got ultrasound traveling down through the liver, hitting the diaphragm, and note how perpendicular the probe is at this point to the diaphragm, so you get a nice bright signal. Whereas here, when the ultrasound is coming down and hitting the diaphragm obliquely, we get scattering or this oblique reflection where this information is not traveling back to the probe, so it's not interpreted as bright. Remember, the number of signals indicates how bright it is. We can also see in this sort of like heterogeneous liver parenchyma, you've got scattering of ultrasound, so it doesn't quite appear as bright as this diaphragm back here, but it's not completely transmitting the ultrasound, right? Some of it's being reflected because of minor differences in the tissue, and so that's interpreted as these variable grayscale. Here in the middle, you get this nice big blood vessel. This is probably part of the portal vascular system, and what we can see is, again, where you go from blood to vessel wall. It's this nice bright signal when you're perpendicular to it. Out here towards the periphery, it's probably bouncing off more obliquely and you're not seeing that bright wall. And then within the vessel, it's filled with blood, so it's going to be anechoic. Bone tends to absorb ultrasound. It's going to reflect a lot of it at the periosteum, and then what's not reflected is absorbed, so you get shadow deep to that. So anytime you're seeing like really dark shadow on the screen, you may be over a rib, so try moving up or down a little bit. Again, just to reemphasize how it works, the machine sends an electrical impulse to these crystals, these piezoelectric crystals in the probe. They vibrate and produce sound that goes into this horrifying meat tissue that bounces off stuff in the tissue and returns. It causes those crystals to vibrate, right? They're sent in pulses, so it's not like a continuous process, but it's a lot faster than you or I would be able to keep up with. The crystals vibrate from the returning ultrasound, and then that information is fed back into the machine, which then produces a grayscale image. Higher amplitude means more reflections, more stuff has come back. That appears brighter. Low amplitude signal, less bright, fewer things have returned from that depth or in that area. So that's why it's called B mode. It's dependent on the brightness. So this is your normal two-dimensional grayscale ultrasound is B mode. Resolution's measured in 3 planes. Axial is the best. If you need to measure the thickness of something, try to get it so that you're measuring up and down on the ultrasound image. We also have lateral and elevational. Elevational is kind of a difficult concept to think about, but it's like, what's behind the thing I'm looking at that's at the same depth and the same sort of lateral space. The actual cut of the ultrasound image is 3-dimensional, but it's mapped in 2 dimensions. So this is just an example of those 3 types of resolution using a model that they've created to standardize how a ultrasound is working. Right, so they know the depth of all of these BBs and how far apart they are from each other in different areas, and then when they take the image, they can like sort of go back to the drawing board and standardize this machine. Speaking about the probes, low frequency tends to give you good depth of penetration. So over here, low frequency is our phased array, the cardiac probe, and the curvilinear or the abdominal probe. They do not give you great resolution. As frequency increases, resolution improves, but depth of penetration goes down. So your high frequency probes that give you good resolution, they can't look very deep into a tissue. That's your trade-off that you have to deal with. So our linear one, this one's high frequency. You got your frequency here. The max frequency on the side is 12 megahertz. So this we use typically for structures that are close to the surface and generally less than 8 centimeters. We use it for like our procedures, for example, when we do central lines and art lines. Our curvilinear probe we're using in the abdomen, and our phased array is generally for cardiac. So again, linear probe, high frequency, things close to the surface when you need high resolution. Curvilinear, low frequency, it's got a big footprint that makes it helpful for viewing the abdomen and seeing quite a bit, and you have good depth of penetration, so you're talking like 20 plus centimeters. Phased array, same with the depth of penetration. The beam is coming from a central point and spreading, so you get this nice sector outline. Poor resolution here in the near field, a little bit better kind of mid and deeper, and it's great for cardiac scanning because of this narrow start to that footprint where you can get in between the ribs. We want to hold the probe close to and the better control you're going to have, just like writing with a pen. You're not going to grab a pen from the back of it. You will look crazy. So try to hold the probe as close to the skin as possible. And I would recommend even anchoring your hand on the patient's body when you're scanning, if it wouldn't be unreasonable to do that, or at least dropping your pinky down to anchor your hand so you're not sliding all over the place while your eyes are fixed on the screen. Get me out of here. There's 4 cardinal motions that we'll mention. Sliding is just translating along a surface, so you're not tilting it or doing anything like that. Fanning, we're imagining a pen is going through the probe marker, which isn't visible in this image, and then we're just tilting it back, tilting it forward. That's to look at things above and below where we're at. Rocking is going to swing things left to right, so it's perpendicular motion to fanning, and this time we're imagining that pin is going perpendicular to that axis that the probe marker is on. Rotating is rotating. Presets, you can imagine them like filters for Instagram or Snapchat or TikTok or whatever the new thing is that people use now. Use your presets. Your presets are your friend, and they help the images to look better. I would recommend the abdominal for pretty much everything except for heart and vascular stuff. So there's a cardiac setting, use that for heart. There's a vascular setting, use that for when you're looking at vessels or doing procedures. Image optimization, we want to focus where the most interesting stuff is. So here in the foreground, you can see that I'm a little blurry, and so is my dad, but my friend Eric Roth here is coming in nice and sharp, and that's because my mom has a hard time taking pictures. So there's Eric. He is not what we're interested in, but he comes out nice and bright. So what we want to adjust on the screen is our depth of field. Notice how there's a lot of wasted space down here at the bottom, like a good 5 to 7 centimeters of wasted space, when this is sort of the important stuff. And then the other thing we want to pay attention to is there's usually this little symbol on the side of the screen. This denotes the focal zone. So our focal zone is kind of where we have the highest concentration of ultrasound signals coming together from each pulse. And so that's going to give us our best information. The other thing you can do is manipulate the gain. Gain is just an after image effect. So think about it like turning up the volume. Your favorite Taylor Swift album was recorded at a certain volume, and then when you crank it up when you're driving down I-29 in your convertible, that's an after production effect, right? The volume is turned up on your radio when you're listening to it, so you can enjoy it a different way. When you're looking at that image and you turn up the gain, you're just telling the computer to make it louder, to make it brighter, but it's not actually doing anything to the signal that it's sending into the body. You can also adjust the gain at different levels in the field. It's called time gain compensation, or TGC, and it looks like a little equalizer thing like a DJ would use on your machine. They're little little dials you can push back and forth. M mode is one of the modes that we use for different measurements, and it maps motion along a line over time. So it just drops a line into your image, and then when you hit M mode again, it's going to give you this map on the bottom. So the line is here, and all of this stuff is the motion along that line over time. So if we zoom in on one section, we've got our RV free wall up there. What's bright up here is going to be bright down here. What's dark up here is going to be dark down here. Next is our septum. And then we've got our mitral valve here, kind of approaching the septum here in diastole. Yeah, I think that was the whole thing. So once you play around with those modes, with M mode and B mode, and try using different presets, seeing how it affects the image, practice switching probes, practice adjusting the depth, see what happens when you change the gain, mess with those dials for the time gain compensation, and then when you're ready to move on as a group, you can go to the next lecture.